Therefore, all African American men with a history of dilated cardiomyopathy is secondary to MI for routine evaluation. He is asymptomatic and is maintained on lisinopril, furosemide, metoprolol, aspirin, and digoxin. Lab tests reveal a potentially elevated level of potassium. EKG is unchanged. Patyromere and zirconium do not control magnesium. What is the best management? Is switch to lisinopril to hydralazine and nitroglycerin. Hydralazine is a direct-acting arterial vasodilator. There is a definite survival advantage with the use of hydralazine in combination with nitrates in systolic dysfunction. Hydralazine does not raise potassium. Candesartan is associated with hyperkalemia as well. Dialysis is used in hyperkalemia only if associated with renal failure as a cause. Do not confuse diastolic dysfunction due to hypertrophic cardiomyopathy with hypertrophic cardiomyopathy. Congenital condition where an asymmetrically enlarged hypertonic septum leads to an obstruction of the left ventricular outflow tract. Diuretics are contraindicated and HOCM because they will increase the obstruction. Transplantation when maximum medical therapy is CI, beta blockers, spironolactone, diuretic, digoxin, and possibly the biventricular pacemaker failed to control symptoms of CHF, then the only alternative is to seek cardiac transplantation. Routine anticoagulation with warfarin is always wrong in the absence of a clot in the heart. Patyromere or zirconium keeps potassium levels low to allow more use of ACE inhibitors such as ARBs and spironolactone. Historic with diastolic treatments. Clearly beneficial systolic dysfunction, diastolic dysfunction. Clearly beneficial ACE inhibitors, ARBs, subcubital vessel losartan, beta blockers, spironolactone, eplerenone, hydralazine nitrates, implantable defibrillator. Diastolic dysfunction, spironolactone, and diuretics. Clearly not beneficial, calcium channel blockers, some even raise mortality. Diastolic dysfunction, digoxin, and beta blockers. Benefit uncertain, ACE inhibitors and ARBs in diastolic dysfunction. Diastolic dysfunction. Diastolic dysfunction in CHF with preserved ejection fraction. Management is less clear. Spironolactone is useful in diastolic dysfunction. Beta blockers have no clear benefit and indicated only for another condition, that is CAD. Digoxin has no benefit and should not be used in diastolic dysfunction. Diuretics are used to control symptoms of fluid odor as they are in any CHF patient. ACE inhibitors and ARBs have no clear benefit. Pulmonary edema. Pulmonary edema is a rapid onset of fluid accumulating in the lungs. It is the worst. There is a more severe form of CHF. Symptoms include an acute onset of shortness of breath associated with real JVD, ST gallop most specific, edema, and orthopnea. There may also be ascites, enlargement of the liver and spleen if there has been sufficient time for the chronic passive congestion of the right side of the heart to prevent filling of the heart. There is prognostic test, brain natriuretic peptide (BNP) if the etiology of the shortness of breath is not clear, and a normal BNP level excludes pulmonary edema. This action will show vascular congestion with filling of the blood vessel towards the head, stabilization of flow. Ordinarily, most flow in lungs is at the base, but because of simple gravity. In more chronic cases, there will be enlargement of the heart and fluid effusions. Oximetry/arterial blood gases. Hypoxia is expected. There is usually respiratory alkalosis because of hyperventilation. Because of the increased respiratory rate, carbon dioxide is more easily than oxygen enters the bloodstream. EKG is most important test to do accurately because it can affect immediate change and treatment. In atrial fibrillation, atrial flutter or ventricular tachycardia is the cause of pulmonary edema. The first thing to do is perform rapid synchronized cardioversion in order to restore atrial or ventricular systole and to return the atrial contribution to cardiac output. Normally, atrial systole contributes only to 10 to 20% of cardiac output. If the heart is diseased from dilated cardiomyopathy, decreased ejection fraction, or valvular heart disease, then atrial contribution to cardiac output can be as much as 40 to 50% of cardiac output. If acute pulmonary edema is from an arrhythmia, the fastest way to fix it is with cardioversion. Echocardiogram in all patients to determine if there is systolic or diastolic dysfunction. It makes no difference acutely if there is pulmonary edema because the initial treatment does not differ. Echo is not needed to manage acute pulmonary edema. Figure 3.6 Pulmonary edema with stabilization of flow and engorged pulmonary veins. A 74-year-old woman comes to ED with an acute onset of shortness of breath, inspired rate of 838 per minute, rate of rapidus, ST gallop, and jugulovenous distension. What is the best initial step in management? C. Intravenous furosemide. See, all of the answer choices can be used in the management of CHF, but the great initial step for acute pulmonary edema is removal of a large volume of fluid from the vascular space with a loop diuretic. Oximetry should be done when oxygen is required, both due to the patient's shortness of breath and hyperventilation. Echocardiogram should be done but later. Amyloid or any other form of ACE inhibitor or ARB should be used if there is systolic dysfunction with low ejection fraction, but makes no difference in an acutely unstable patient. Same is true of metoprolol. Nesutide is an intravenous form of atriotractive peptide which functions similar to nitrates. There is no mortality benefit. Here 3.7 Jugular distension. Treatment: preload reduction, oxygen, loop diuretics of furosemide or bumetanide, nitrates, genders, and reinfection and aortic stenosis. Morphine, loop diuretics such as furosemide or bumetanide. Nesutide is not more effective than diuretics and nitrates. Move 1 to 2 liters of fluid from the vascular space and the lungs to decrease symptoms. Furosemide is a pulmonary vasodilator too. Positive inotropic agents: when there is no response to preload reduction, we put dopamine acute setting only. Amrinone and milrinone are phosphodiesterase inhibitors that perform the same role. They increase contractility and decrease afterload. Digoxin, chronic setting only, increase contractility but only after several weeks of use. Afterload reduction: ACE inhibitors and ARBs are used on discharge for long-term use in all patients with systolic dysfunction and no ejection fraction. Nitroprusside and intravenous hydralazine, acute setting only. Repair is always wrong for acute pulmonary edema management in the absence of a clot. Valvular heart disease. All valvular heart disease can be congenital in nature. Hemorrhagic fever can lead to any form of valve disease, but mitral stenosis is most common. Aging can automatically be associated with aortic stenosis. Regurgitation disease is most commonly caused by hypertension and ischemic heart disease. Infarction automatically leads to regurgitation, which automatically leads to dilatation. All forms of valvular heart disease are associated with shortness of breath and many of the signs and symptoms of CHF. Only the murmurs are specific in terms of presentation. Lesions on the right side of the heart, tricuspid and pulmonic valve increase intensity or loudness with inhalation. Inhalation will increase venous return to the right side of the heart. Left-sided lesion, mitral and aortic valve increase with exhalation. Exhalation will squeeze blood out of the lungs and into the left side of the heart. Diagnostic test. For all valvular heart disease, echocardiogram is the best initial test. Transesophageal echo is more sensitive and more specific than transthoracic echo. Catheterization, most accurate test, allows the most precise measurement of valvular diameter as well as the exact pressure gradient across the valve. Even though EKG will show hypertrophy of chamber, it is not specific enough for valvular heart disease. Similarly, even though chest X-ray will show hypertrophy and enlargement of the various cardiac chambers, it will not provide a precise anatomical correlation. X-ray is neither the most accurate nor the best initial test. Treatment: all forms of valvular heart disease are associated with fluid overload in the lungs, so diuretics are always helpful. For stenotic lesion of the mitral and aortic valve, correction of the anatomy of the heart, mitral stenosis needs dilatation with a balloon, aortic stenosis needs surgical removal or replacement by catheter. For regurgitated lesions, vasodilator therapy with ACE inhibitors, ARBs, nifedipine, or hydralazine. Surgical replacement must be done before the heart dilates too much. In other words, if the heart dilates excessively, heart replacement will not be able to correct the decrease in systolic function. If the myocardium stretches too much, it will not return to normal size and shape. Ventricular size is based on the end systolic diameter and the ejection fraction. When the end systolic diameter expands, the valve must be replaced. Endocarditis prophylaxis is not indicated for any of these valve disorders unless the valve has actually been replaced or there has been previous endocarditis. Mitral stenosis. Mitral stenosis is most often caused by rheumatic fever. Mitral stenosis is extremely rare in the United States because of the very low incidence of the acute rheumatic fever. Critical narrowing is defined as a valve surface area less than 1.1 cm square. However, the main ingredient for treatment is the presence of symptoms. There is not much point in treating mitral stenosis that is asymptomatic. Most patients with mitral stenosis are immigrants to the US coming from geographic regions in which acute rheumatic fever is still common. Pregnancy is associated with 50% increase in plasma volume, which must transverse a narrow valve. In addition, during delivery, contraction of the uterus can squeeze as much as 500 ml of extra blood into the central circulation, thereby inducing pregnancy-related cardiomyopathy. Mitral stenosis often presents in young adult patients. Tip: look for pregnancy and immigrant status and the history as a clue to asking what is the most likely diagnosis. Figure 3.8 Mitral stenosis. Besides the usual shortness of breath and CHF associated with all forms of valvular heart disease, mitral stenosis has some unique symptoms. Dysphagia from left atrium pressing on the esophagus, hoarseness left atrium pressing on laryngeal nerve, atrial fibrillation and stroke from enormous left atrium, hemoptysis. Figure 3.9, 3.10. Enlarged left atrium in mitral stenosis compresses the esophagus, causing dysphagia. Left alveolar compression. Enlarged left atrium compresses the esophagus, causing dysphagia. Enlarged left atrium pushes up left main stem bronchus, causing dysphagia. Left as well as compression and displacement of the left main stem bronchus. Murmur is in diastole just after an opening snap. Squatting and leg raising increase the intensity from increased venous return to the heart. Diagnostic test TTE, peritoneal test with TTE more accurate than TTE. TE, transesophageal echocardiogram more accurate. Catheter most accurate test for all valve diseases. EKG, atrial rhythm disturbance, particularly atrial fibrillation, very common. Left atrial hypertrophy showing up as peripheral P wave in leads V1 and V2. Chest X-ray, left atrial hypertrophy, training of the left heart border, elevation of the left main stem bronchus, second bubble behind the heart. Treatment: diuretics and sodium restriction when fluid overload is present in the lung. Balloon valvuloplasty done with a catheter. Valve replacement of the catheter procedure cannot be done or fails. Warfarin for atrial fibrillation between INR 2 to 3. Rate control of atrial fibrillation with digoxin, beta blockers or diltiazem plus verapamil. Peristalsis and metal heart valves are the two remaining indications for the use of warfarin. All others with atrial fibrillation and Schadt's valves greater than 2 use NOAC.